So the first cranial nerve is olfactory. It is responsible for a sense of smell. A dysfunction in this nerve would result in anosmia or the loss of smell. For this one, I'm going to have two unknown smells. You'll be able to recognize them, but I'm going to have you close your eyes for me. Okay, and then can you cover one nostril for me? Alright, so I'm going to wave this in front of you. Can you smell it?
Coffee.
Very good. Okay, can you cover your other nostril? Yep. Okay, same thing. Can you smell anything?
Peppermint.
Perfect. So cranial nerve number 2 is optic. It is a sensory nerve. It is responsible for visual acuity and afferent for pupillary responses, which we will not be testing today. Dysfunctions of this nerve involve a decline in visual field as well as distorted vision. We're going to be assessing your ability to read a Snellen chart, so I'm going to have you cover one of your eyes for me. Okay, can you read line number 8?
DEFPOTEC.
Great. Can I have you switch your hands and then read number 8? Actually, read number 9 if you can, backwards.
TCPDOFEL.
Perfect. Okay, so now we're going to have a seat. I'm going to assess your peripheral vision. Okay, I'm going to have you look right at me and let me know when you can see my fingers.
No.
Can you point to the one that's moving? Good. Okay, good. Now I'm going to have you cover one of your eyes for me. Okay, let me know when you can see it.
No.
Okay, switch hands.
No.
Good. Okay. Next we'll be testing cranial nerves 3, 4, and 6 together. This is going to be oculomotor, trochlear, and abducens. The oculomotor is responsible for elevating the eyelid. It is involved with tracking the eye up, down, and in, and constricting the pupil, as well as accommodating the lens. Trochlear is involved with inward rotation of the eye, so we can call this convergence. Abducens is responsible for turning the eye out, so in the lateral direction. Common dysfunctions of these nerves involve strabismus, which is a condition where the eyes don't properly align with each other. You may also have nystagmus, diplopia, or double vision. Ptosis of the eye is more specific for oculomotor with the eyelid. Nystagmus, that would be in the more so in the end range of abducens, and possibly light reflexes will be impaired. Okay, so for this next test, I'm going to have you look just right at this pin and just follow it smooth. Okay, so this is a smooth pursuit test. I'm just looking at her eyes, looking for nystagmus, the end ranges specifically. Okay, very good. I'm going to have you compared. Okay, that's going to be the trochlear nerve. Okay, I'm going to have you cover one eye. Okay. He's looking for constriction. Oh, I'm going to do the other one. Okay, actually, I'm just going to do, yeah. That's constriction. Okay, now I'm going to go ahead and cover one eye. Now I'm just looking for dilation of the opposite eye. Okay. Other side. Perfect. Okay. So I'm going to have these two fingers. I'm actually going to have a thumb, finger, and I'm just going to have you look at my thumb, finger, thumb, finger, thumb, finger. Good. Looking for spots. So next is cranial nerve number 5. This is trigeminal. It's both a sensory and motor nerve, so it tests for the sensation of the face, cornea, and the anterior tongue, as well as the muscles of mastication. Some dysfunctions seen with this nerve involve a decreased or abnormal sensation in light touch and or sharp dull, atrophy when palpating the muscles of mastication, and asymmetry with jaw strength and or with palpation, and an increased jaw jerk reflex. Okay, so for this test, we're going to be testing light touch sensation. I'm going to be using a cotton ball. I'm going to demonstrate it on your hand real quick so you can see what it feels like. This is really light. Okay, I'm going to have you close your eyes. I'm going to be testing the 3 locations on your face. And just tell me yes if you feel it.
Yes. 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 Yes.
Okay, perfect. Okay, so this next one is going to be sharp dull. So this is going to be your sharp end. This is going to be your dull end. It's not really that sharp. Don't let it intimidate you. So I'll go ahead and test it on your hand here just so you're a little bit more comfortable with it. Not too bad. Okay, so I'm just going to wipe it off real quick. Okay, so same thing, eyes closed, but this time you're going to tell me if it's dull or sharp, okay?
Sharp. Dull. Sharp. Dull. Dull. Sharp. Dull. Sharp.
Okay, very good. All right, now I'm going to test the motor portion of it. I'm going to have you clench your jaw for me. Is that okay, guys?
Mm-hmm.
Okay. I'm just feeling for symmetry. Okay, can you open your jaw just a little bit? Don't let me move you. Good. Now open just a little bit. Don't let me move you. Good. Okay, I'm going to test your reflex. Just open just a little bit. Perfect. So next we will be testing cranial nerves 7, 10, and 12. This is facial, vagus, and hypoglossal. These are also easily tested together as a group. The functions of these nerves for facial, it involves the muscles of facial expression, salivation, and tearing. It also involves taste of the anterior 2/3 of the tongue, which we will test. For the vagus nerve, it involves the muscles of the larynx and pharynx, which we will observe by palpating the patient's swallow. It's also responsible for thoracic and abdominal viscera, decreased heart rate, and increased motility of the GI, which we will not be testing today. Hypoglossal nerve is responsible for tongue movement and shape. Some dysfunctions associated with these nerves involve asymmetry with facial expressions, or the patient may not be able to identify or taste anything with the taste test. For the vagus nerve, we may palpate asymmetry with swallowing. We may observe hoarseness in their voice when they say ah. We will also observe asymmetry of elevation of the soft palate and uvula. For the uvula, we will see it deviate towards the lesion for an upper motor neuron and away from the lesion for a lower motor neuron lesion. For the hypoglossal nerve, we may observe the tongue deviating to one side. In this case, an upper motor neuron lesion would mean the tongue would deviate away from it, and a lower motor neuron lesion, the tongue would deviate towards. Further tests would be needed to identify this. For the hypoglossal as well, we may observe garbling or decreased articulation with speech. Okay, so for this test, I'm going to have you smile. Okay, can you frown for me? Puff your cheeks. Good. Can you close your eyes really tight? Okay, don't let me move them. Other one. Yep, very good. Okay, so this next test, I'm going to be testing the anterior 2/3 of your tongue. Let's see if you can taste, if you're able to taste on both sides. So for this, I'm going to have you close your eyes for me. Okay, just give me 1 second. Okay, can you stick your tongue out for me? I'm going to have you taste and try to keep your tongue out. What do you think that is?
Sugar.
Sugar? Very good. Okay, can you stick your tongue out for me? Very good.
Salt.
Good. All right, can you swallow for me? One more time. Very good. Can you open wide? Say ah.
Ah.
Okay, very good. Looking for hoarseness and looking to see if her uvula is symmetrical. Okay, can you stick your tongue out for me? Okay, very good. I'm just looking to see if her tongue deviates to the side. Next we have cranial nerve number 8. This is vestibulocochlear. Its function is balance and hearing. Some dysfunctions associated with this nerve involve if the patient is unable to focus on one point with the head movements for the VOR test. They may experience dizziness, nausea, or other symptoms. For the Weber test, if the person had conductive hearing loss, they may have the tone localized to the affected ear, whereas a sensory neuron hearing loss, it may be localized to the good ear. The Rennie test, a positive test would be if the bone conduction was louder than the air conduction. For the tilt test, tilt head test, the patient may experience dizziness, vertigo symptoms. Same for the Dix-Hallpike maneuver, they may experience vertigo signs as well. And for the finger rustle test, they may not be able to hear the rustle on either side. Okay, so for this test, I'm going to be testing your hearing and balance. I'm going to have you close your eyes for this test. Can you point to the hand when you hear a rustle? Very good. Okay, so this is going to test your VOR. I'm going to have you stick your thumb out just like this. And on my cadence, I'm going to have you keep your eyes focused on here. On the cadence, you're going to turn your head, but keep your eyes focused on here, okay? So ready? 1, 2, 3. Okay, very good. I'm just looking at her eyes, make sure they stayed focused. Okay, so for this next test, I have a tuning fork. I'm going to have you close your eyes. Does it feel the same on both sides?
Yes.
Feel the same on both sides?
Yes.
Okay. This louder or is this louder?
First one.
Okay. Is this louder or is this louder?
First one.
Okay, very good. So for this portion of the test, I'm going to have you turn your head really sharply to the left, okay? And you're going to do your best to keep your eyes open, okay? Ready? 1, 2, 3. Okay, so I'm looking for any signs of vertigo, nystagmus. Are you feeling dizzy, nauseous, or any of these symptoms?
Nope.
Nope. Okay, still looking at her eyes. Okay, you're going to return back, and we're going to do the same thing on the other side, okay? 1, 2, 3. Any symptoms?
Nope.
Okay, very good. We're going to go ahead and sit up for me. Alright, so for this one, I'm going to stabilize your head. Hand face me. Can you grab onto my arm for me? Alright, so what we're going to do is we're going to lay back really quickly, and I'm going to want you to keep your eyes open, okay? 1, 2, 3. Okay, so I'm going to stay here for about 30 seconds, looking at her eyes, again looking for vertigo. Are you feeling any dizziness, nauseous?
Nope.
Okay, so 30 seconds is up. We're going to go ahead and sit up. Okay, keep her here. Again, looking, nothing here. Alright, and then we're going to go ahead and repeat this test on the other side. Okay. So lastly, we will be testing cranial nerve number 11. This is spinal accessory. Its function is head movement, specifically of the sternocleidomastoid and the upper traps. Dysfunctions associated with this nerve involve asymmetry, weakness in the upper traps or the sternocleidomastoid. We may observe atrophy or a shoulder girdle dysfunction, such as scapular winging, all associated with any dysfunction with the sternocleidomastoid or upper traps. Okay, so our next test, I'm going to test your spinal accessory nerve. That's going to be your upper traps and your sternocleidomastoid. Alright, so I'm going to screw just a little bit towards the edge. Yep. Okay, I'm going to get a little bit close to you, and can you elevate your shoulders for me? Yep. Now let me move you. Okay, very good. Normally I would stand in the back, but I'm concerned about the patient's safety, so I'm going to stand here in the front for that assessment. I'm going to have you turn your head to the right. Okay. Don't let me move you. Good. And the other way. Don't let me move you. Very good.